Before we start, we wanted to be sure you were aware of a few details that will make the symposium run smoothly. Attendees will be muted for the symposium. The speakers will answer questions after their presentation, time permitting. Questions should be put into the question and answer box. The moderators will monitor the question and answer box throughout each presentation. Questions are encouraged. For this symposium, you must attend all sessions and remain logged in for the entire symposium to obtain continuing education credits. No partial CEUs are available. The symposium will be recorded and the video and resources will be available next week. We are pleased and honored to have national and regional speakers. Please welcome Dr. Ann Nolan, School of Nursing Director at Florida Gulf Coast University, as we start today's symposium.
Good morning, everyone. On behalf of the School of Nursing at Florida Gulf Coast University, I would like to welcome you to our symposium on value-based care and telehealth. We have an excellent array of presenters who will be taking us through an examination of value-based care and telehealth impact on access and outcomes. Pertinent political, interprofessional, reimbursement, and outcome dimensions will be explored. We are very excited to offer this symposium today, and I want to thank our HRSA, a new grant team, for all of the efforts that they made in organizing this event. I hope you enjoy the day. And now it is my pleasure to introduce Dr. Ann Carey, Dean of the Merritt College of Health and Human Services at Florida Gulf Coast University. Dr. Carey.
Thank you, Dr. Nolan. I'm Ann Carey, Dean of the Merritt College of Health and Human Services, and just delighted to join our colleagues from around the nation as together we learn from our national experts about the nuances of value-based and telehealth delivery. The Merritt College of over 2,700 students at FGCU educates 9 health professions disciplines from baccalaureate through doctoral degrees, and we value interprofessional learning and team care. I want to thank our workshop organizers for their hard work in bringing this day to us. We know that with the aegis of pandemic that we're experiencing a more rapid acceleration of telehealth and a pressing need to optimize our value-based care approach. A leisurely, phased-in approach to each has been replaced by an acceleration and a learn-as-we-go approach. While we may have missteps, we're also accompanying this acceleration with a rapid learning deployment and corrective action to achieve the outcomes we all desire. That is, increased appropriate access, quality and safety, and cost effectiveness. CMS has actually led the development of value-based care payments to an excess of 50% of total payments now paid through value-based methods. However, the biggest barrier to success of value-based implementation and success has been provider engagement. We know that value-based care depends on access to data analytics and dashboards, population engagement and care management, and evaluation and prioritization of wraparound and non-clinical incremental services. So because you're an audience of providers, health plans, health systems, and third-party administrators, we hope you will find this day supportive of new learning, critical thinking, and a penchant for action. We appreciate your engagement and the participation by all our esteemed speakers today joining us. To kick off the day, we're so pleased to hear from Dr. Margaret Flinter. Dr. Flinter is the Senior Vice President and Clinical Director of the Community Health Center, Inc. As a family nurse practitioner since 1980, she's held progressive roles in the organization as both a clinician and executive leader, as it transformed from a storefront clinic to one of the country's largest federally qualified health centers. In 2005, she founded Community Health Centers, Inc., Weizmann Center, as a research and development arm, now the Weizmann Institute. Margaret also served as the national co-director of the Robert Wood Johnson Foundation's LEAP project, which is studying exemplary primary care practices across the country. Margaret has led the national development of model postgraduate residency training programs for new nurse practitioners committed to practice careers as primary care providers particularly in the safety net settings, and established the National Nurse Practitioner Residency Training Consortium. She's the co-host of a weekly radio show, Conversations on Healthcare, which connects people with the issues of health policy, reform, and innovation. And she speaks widely on issues related to topics of primary care transformation. Margaret received her BSN from the University of Connecticut, her MSN from Yale University, and her PhD from the University of Connecticut. She's a fellow of the American Academy of Nursing, where she co-chairs the expert panel on primary care, and a fellow of the American Academy of Nurse Practitioners. She's also a former National Healthcare Service Corps member and a Robert Wood Johnson Executive Fellow. Dr. Flinter is a national leader in value-based care and provides expertise around the country. Dr. Flinter, we welcome your remarks and we welcome you to today. Thank you.
Well, good morning and thank you. And I'm going to try and live up to that very kind and generous introduction. But thank you so much for inviting me to be here with you this morning at your Value-Based Care and Telehealth Symposium. I wish I could be with you in person, as we all these days, I think, long for more of our old physical connection, but maybe given the focus of today's symposium, it's actually more appropriate that we're doing this virtually. I thought I would ask my assistant here to make us feel like we're a little more in physical space connected by beaming me onto a shot of Main Street, USA, Main Street, Middletown, Connecticut, and our primary care center here in Middletown, just to give a sense of physical place. And I wish I could see where all of you are today, but you're probably in your home offices, your living rooms, and various other spots. What a time to come together for this symposium. I could not launch into this talk without stopping to acknowledge the pain, the suffering, the devastation that has gone on in our country over these last couple of months, first brought to us by the COVID pandemic, and then more recently, the grief and the anger and the hurt that has swept across the country following the death of George Floyd. And as we see people taking to the streets, demanding action and demanding that we resolve to move forward and improve upon our past in this country. There is so much work to be done. All of us in healthcare have the privilege and the responsibility of relieving suffering and improving health. And really, that's what my talk is about today. It comes out of my deepest belief that healthcare is a right and a privilege, and that it is a lever, a powerful lever, not the only lever, that we can use to create a more just and fair and safe society for all people. Healthcare is a right. Access to healthcare is fundamental to that right. But we always ask ourselves, access to what? Our charge, our collective charge, is to make sure that the answer to this is access to high quality, highly effective, fully integrated, culturally competent, sensitive, humble primary care that is responsive to the needs of our individual patients and our populations of patients. And in the classic Barbara Starfield definition of primary care that most of you probably remember from some point along the way, care that is taking care of all but the most unusual and complex conditions, and sometimes I think those as well, that is comprehensive, that's delivered in the context of a relationship over time, and delivered close to where people live, work, play, and pray, and at a cost that's acceptable to the individual and to the society. So we have a lot to live up to there. I imagine that I'm speaking today to a diverse audience, and I heard a lot of different groups of people who are here today. I didn't hear students, but I'm certainly hoping students are here today because I'm speaking to the next generation always when I talk. But I imagine the audience is diverse in age and gender and race and ethnicity and sexual orientation, diverse in professional disciplines and fields of study or practice. And I hope we have both students and seasoned veterans with decades of experience here. So I want to say thank you to those veterans of decades of experience, but I want to say thank you to those of you who are just starting out even more, because I know that you're going to do great things. I'm going to try and speak today from the perspective of what I call feet on the ground, pragmatic, disciplined approach to making healthcare better today, and also eyes on the horizon, aspirational, focused on the future that we're trying to create. I was gifted with a generous amount of time, but that can run out quickly, and I don't want to take all of it because I know we'll have questions. I'm going to organize my comments into 3 sections. First, some background on my organization as a community health center as part of the national system of community health centers. Second, our work to transition to a truly population-focused, value-based model of care, what the terms mean and how we translate them into care and practice, how they affect patients, and how they impact interventions and outcomes in care, cost, and quality. Third, how telehealth in primary care has just exploded since the onset of this pandemic. We're going to ask what enabled this growth spurt? What does it take for success? How can a primary care practice transition to telehealth? And how do our patients feel about it? In quality, in access, in satisfaction? And what about the digital divide of those for whom access and ease of use may be great and those for whom it is not? The paradox of this pandemic, probably one of many, does seem to be that for all the suffering and the turmoil, it has catapulted rapid change that I think may have profound value going forward for our patients and populations. Then we'll try and tie all this together with our discussion. So first, let me just tell you a little bit about this organization. The Community Health Center started as a free clinic in 1972, committed to the principle of healthcare as a right, not a privilege, never moved away from that, had a patient consumer majority board even when we were a free clinic and not recognized as a community health center. Today, we care for over 100,000 patients every year. We are statewide with 15 major primary care hubs across the state that touch the borders of Rhode Island, Massachusetts, and Rhode Island, and New York, and then all the major cities in between. These primary care centers are the hub for a wide network of school-based health centers, which reach 19,000 students a year, for our healthcare for the homeless clinics that are in shelters and food pantries, for our migrant farm worker clinics, and many points in between. But we believe if you're going to be in the business of delivering healthcare, you really ought to be in the business of improving healthcare and contributing new knowledge to the field. And out of this came the Weitzman Institute, which was named for a beloved early and longtime board member and community pharmacist, Jerry Weitzman, who I like to say never met a new idea that he didn't like. The work of the Weitzman Institute, hand in hand with the care delivery side of the house, are its 3 pillars of research, innovation, and education and training. And this has brought us into connection with thousands of providers and practices and healthcare leaders all across the country and made us a hub for educating and training the next generation. Now, many of these innovations were created by people just like you, who saw a need, had an idea about how to meet it, and at least some cases came up with a solution that didn't just help our patients, but could be scaled up to help providers and organizations solve life's persistent problems in healthcare and contribute real value. Innovations like e-consults, which solved a decades-long problem of access to specialists for uninsured and often for publicly insured patients. NEMA, the National Institute for Medical Assistant Advancement, a whole new model of educating and training medical assistants, postgraduate training in FQHCs for nurse practitioners and clinic psychologists, and Project ECHO, which I think has really been one of our most influential projects that has connected us with thousands of primary care providers, nurses, behavioral health specialists, pain specialists all across the country as we work to connect teams of multidisciplinary specialists, expert in addressing a major problem with frontline primary care people all across the country over time using real cases, discussion, sharing, and didactic to master that. And in the process, I think we've really built a strong community for primary care on top of the community that was already there. And last, the Center for Key Population, the first of its kind to really in a primary care system pull together a whole group of patients who have in common different major health challenges, but they all require more than even our usual high level of integrated primary care in order to address it. And certainly in the last year or two in particular, with a huge focus on addressing opioid use disorder. And finally, we're committed, as so many of you are, to educating the next generation through a whole series of initiatives, which we can perhaps talk more about at another time. But when we are training that next generation, make no mistake about it, We need to be training them not just to clinical competency, but we need to be training them to high performance models of care. And that's why I'm so glad that you've chosen to make this topic of population health, value-based care, and telehealth part of your symposium today. All in all, I'd say we've come a long way from the storefront clinic that I joined almost 40 years ago as a new nurse practitioner and National Health Service Corps fellow and National Health Service Corps scholar, came together with a group of amazing people, and together we've built the organization that you see today. And I say to any of you who are out there in your 20s, never forget, you can create anything that you have the vision to imagine, and we wish you luck in that path. And maybe just a little bit about community health centers and the national system of health centers. Community health centers are everywhere in America, caring for nearly 29 million people. You've got a wonderful group of 47 community health centers in Florida that care for 1.5 million people. And I think right there in Fort Myers, where you're headquartered, you have the Family Health Centers of Southwest Florida. Glad to say we have quite a few people from Florida who join our Project Echoes every week. Now, the health center system is the largest primary care system in the United States, caring for 1 in 12 people. But I think the point I want to make today is that the health center movement is in fact the forerunner of population health and value-based care. And I'll tell you why I say that. From its earliest days, even before it was written into federal statute, the early leaders, people like Dr. Jack Geiger, focused on data, pen and paper. And I have wonderful photographs from some of those first clinics, big sheets of poster paper on the walls, looking at birth outcomes, looking at infant mortality, looking at rates of infectious diseases, and some of the social problems that affected people, paying attention to specific populations. So when health centers were written into federal statute, this approach, which was then called community-oriented primary care, was picked up. Then and now, a community health center has to define their service area geographically, define their target population to focus on, identify the health challenges that particularly face that population, and consider the availability of healthcare by the number and the type of healthcare providers that are available to that target population. Because this audience knows full well, it doesn't matter how many healthcare providers we have if they aren't available to all of the people in the community. If anything, this is even more important today. And I certainly note that other systems, Kaiser Permanente in the private sector, the VA in the public sector, and both for-profit and not-for-profit health systems have adopted a strong population health approach because they know they need to understand the needs of their people. So what are we talking about when we talk about population health? Good to get our definitions clear up front. I like this definition. The health outcomes of a group of individuals, not just the individual, but the group, including how the outcomes are distributed within the group. As I said with the community health center work, focusing on populations within specific geopolitical areas, think census tracts, think towns, think counties, but it goes beyond their clinical health to include what we now often think of as the social determinants of health: social, economic, environmental, and also individual behavioral and genetic traits. And the CDC goes on to say that population health brings significant health concerns into focus and addresses ways that resources can be allocated to overcome the problems that drive poor health conditions in the population. And I know the folks at the university are well familiar with this from their work with homeless populations, from their work with patients living with HIV/AIDS, working with families who are disadvantaged, working with people who suffer the consequences of serious behavioral health illnesses. These are all populations within the larger population and deserve special attention. This, of course, has been incredibly apparent to us during the COVID-19 pandemic, as we saw the differences between rates of death and rates of serious illness and even rates of infection among our African American and Latinx populations. Actually, let me just go back here for a second. So let's talk about value-based care then. Value-based care, again, using some formal definitions, is a healthcare delivery model in which providers, including physicians and hospitals and other healthcare providers, are paid based on patient care outcomes. Providers are rewarded for helping patients improve their health, reduce the effect and incidence of chronic illness, and live healthier lives in an evidence-based way. Again, so much to say, so hard to do. But the value in this case, and I think this is really the important piece, is derived from measuring those outcomes against the cost of delivering the outcomes. And that is wrapped up in all of the agreements that those of you who have value-based plans in place understand. And this value extends to all, to patients, providers, payers, suppliers, and society as a whole. So both population health and value-based care then focus on improving health and outcomes, increasing the spending that is purposeful and has impact, and reducing that which does not, and securing appropriate reimbursement for the additional costs of doing this value-based work. Now, some of you, like me, may chafe a little bit at this value-based care and value-based work and value-based payment as if what we have been doing all along was not high value. I try and just suspend my feelings on that and recognize that this is a classic definition, and this idea of making sure that there is a relationship between what we invest in and the outcomes we get, I think is useful. But why do we want to do this? Well, I start with, because we are so aware now more than ever that fundamentally one of the biggest disparities in our country is that some people's lives are shorter because of the inequities that we see in health, and that those inequities are based on social as well as clinical issues. So I start with, we want to help people live longer lives. We want people to have an equal shot at the years of life that they can enjoy. Certainly happier lives, perhaps free from pain and disability, reduce racial and ethnic disparities is fundamental to all of it, improve control of chronic illness, and ultimately, we want to build healthier communities that we all can live in. If we can improve health, close care gaps, achieve better outcomes, reduce health disparities, and achieve overall cost savings for individuals who are enrolled in a value-based plan, then we can do it for everybody. And this is particularly important for us in a country that still does not ensure every single person and guarantee them access to healthcare. A rising tide lifts all boats. If we can do this for the people in a value-based plan, we can do this for everybody. And I think that is a worthy goal. And again, I want to keep us grounded in this moment of the COVID pandemic, and I direct people to the CDC for some wonderful resources. But there is no doubt, although I know it's going to take a long time for all the data to be out and to be analyzed, but there's no doubt we have seen profound disparities in illness and death among our African American and Latinx population, and we need to be very aware of that. I'm going to pivot to the system of care that gives rise to population health and value-based care. And we like to say in my organization, every patient has a team. But how does that team get to this value-based population health? We have good evidence on what is effective in primary care in this dimension and what can be further strengthened in value-based plans. And that is high-performing primary care teams, just like this one. Like everything, easy to say, harder to do. But I hope you agree with me that none of us can do this work alone, and that old models of silos and hierarchies of separation of services and limits to practice other than that which is governed by law, training, and competency work against us, not with us. Who's on that team varies from practice to practice. At the heart is usually the team lead of a primary care provider, a nurse practitioner, a PA, or a physician, and a medical assistant. But for most practices, as they evolve, they recognize that they need to include registered nurses and behavioral health specialists at a minimum. The addition of other roles happen as practices realize the value proposition, and there does have to be a value proposition for the patient and the organization. In my organization, that has led to adding chiropractors everywhere as part of our strategy to address chronic pain, to add registered dietitians and podiatrists based on some of the major health concerns in our population, very specific to our patients. And these disciplines are not working in silos, but they're working in teams. They share data and patients. They collaborate in real time in between visits. They use electronic dashboards to identify and resolve gaps in care and manage the space between the visits. They are truly practicing at the top of their license, and there's always a place for a student or a trainee in this system. Hence, the pod that you see, one of the practical innovations in primary care that replaced the old days of the provider's office, the nurse's station, the medical assistant's counter, with a far more connected and you could say socially egalitarian environment. It might be one pod in a small community, in a small school-based health center, or 15 pods in a large primary care center, but the underlying concept is the same. This is a group of people, each expert in their own role and in working in concert with all other roles with the patient at the center. And this is fundamental, that concept is fundamental to providing value-based care. No one person can manage all of the care for all of the patients. Now, you might reasonably say, well, hasn't this model gone out the window in the current pandemic? And certainly for our care teams still on site, which is a reduced number as more have transitioned to telehealth, it looks different. People wear masks, they social distance, and we've reduced the number of people in any given space. The exciting news for our virtual teams is that during a period of time when we have transitioned all of behavioral health and about 90% of medical care to telehealth, we've shown that we can replicate a high-performing team-based model, fully integrated in a virtual environment. And I've come to say where team-based choreography replaced team-based geography and physical proximity. And I want to share this slide with you for your review later, maybe just to give people who are still at the early stages of designing their value-based plan a look at kind of the macro level points of integration between major services of what I call both the on-stage players and the off-stage players who come together representing the disciplines and the expertise that makes this happen. And maybe a special shout out today to any of our off-stage players in the audience, the data analysts, the trainers, the people who we simply could not do our work without. Now, there's strong evidence for organizing care this way. As was said, I had a chance to co-lead, it's now over, the LEAP project, Learning from Effective Ambulatory Care Practices, which was a Robert Wood Johnson national project in which we looked at 300 practices nominated as high performance and narrowed them down to 30 that met criteria as highly effective practices that represented private, public, rural, urban, FQHC, academic training sites. And the surprises or the findings won't surprise you there. In really high performing primary care settings, providers and their panels are supported by core teams consisting of medical assistants and others. All core teams are supported by RN care managers, behavioral health specialists, pharmacists. There are medical assistants playing these key patient care roles. The roles are expanded and all patients are empaneled. They all belong to part of a team. And increasingly, we have to focus in primary care on the social determinants of health, not just recognizing generally they affect our population, which they do, but individually, who is encountering what adverse social determinant of health, food scarcity, housing instability, living in violent situations. And we're expected to do something about it. Not solve the problem, which is often beyond our capacity, but have the linkages with other organizations where we can try and do that. So if you have a base of strong primary care to build upon, how do you make the transition to a formal population health focused value-based system? And should you? I would suggest that the time has come for anyone who hasn't moved forward on this to do so and do it intentionally because it has the power to help us achieve those aims that we discussed earlier, longer, healthier lives. And because I guarantee you that somewhere, someone is looking at your practice, your patients, your spend, and the return on that spend. And policy decisions, practice decisions, investment decisions are being made on the basis of what they see. And you, particularly our up and coming next generation of clinician leaders, want to be informed, active, and engaged in this policy decision. Now, I'll share some of our experience in a major transition to value-based care. 2016, the state of Connecticut announced a new initiative, PCMH Plus, or Patient-Centered Medical Home Plus, not to be confused with the NCQA, PCMH. Participation was voluntary, but we jumped at the chance to have 55,000 of our established patients attributed to the program. Medicaid was clearly very intent on improving their health. Every effort had been made to prevent underservice. There's an upside financial opportunity based on cost savings overall, but you only received any of it if you achieved clinical performance measures at a pretty high level. no downside financial risk to the organization, and importantly, a per member per month payment of $4.50 to help support the new resources that would be needed to have a prayer of accomplishing all that was asked of us. We moved forward kind of cautiously on this. We used existing staff for key leadership positions, people we had a lot of confidence in, created the population health department, and moved one of our expert quality and data people into the leadership role there. Along with our chief medical officer, I took the executive leadership position, and we began to make our first and lasting investments in staff additions that were essential, but really could not have done their work without our QI team, our process change people, to help drive that change. Nor could it have been done without the willingness of our staff at all levels to embrace change, and our data people to take advantage of the timely data that we now had for the first time on where our patients were, anywhere and everywhere, and the cost of the care they were receiving. And this in and of itself was a huge step forward. And we were challenged to add new interventions in the hopes of improving health outcomes. Now, as you can see, we were given a set of quality measures, 9 specific quality measures, 4 challenge measures, and then 14 measures we had to track and report on, though they weren't part of any incentives. They spanned pediatrics and adults, medical and dental, behavioral health. Beyond these measures, we had the whole set of contractual requirements, like convening a consumer advisory committee to keep an eye on what was happening, strengthening systems for children and youth with special health care needs, and focusing on other key populations that our legislature and advocacy community wanted to make sure were included. We agreed that all the measures were important and of value. They came from respected sources like the NCQA and AHRQ, though some came directly from our Connecticut Medicaid Authority and, again, our advocates. These measures have changed over time as targets were hit, and as the legislature looked at other issues. You'll see in 2021 now it's not just reducing emergency room visits, it's reducing avoidable emergency room visits, and increased focus on the hospitalizations, which were once just reducing hospital readmission, now are reducing avoidable hospital admissions in the first place. Now, if you move into value-based plans, you're going to be measured likely in terms of performance, your own comparison to your own past performance, comparison to other people in the plan, and then comparison to national benchmarks. But you want to know these things. You can't improve unless you actually know where you're starting from. And so, you know, today we share our data. If some of it's great, some of it's not as good as I would like it to be. 2016, 2017, 2018. I'm very proud of our driving of emergency department usage down. In our current COVID pandemic, a lot of worries about people not going to the ER when they should, but we know that this was done very intentionally through lots of additional supports, lots of additional early access to care, and also of our progress in making sure that we're doing developmental and other behavioral health screening in the early years of childhood. And I assume most of you see some kind of data like this. Now, the challenge measures were measures that we did, I would say we did pretty well in behavioral health screening, post-hospital admission follow-up, metabolic monitoring, readmissions within 30 days. Everybody's story in a value-based plan is different, and there are a few guarantees. I think that's the whole point. It was great that we had some upfront PCMH plus monthly payments, but really we had no idea whether we would recoup our entire investment or whether we would get a dime of savings. And so this is public knowledge, so I'll share this with you and I'll put it in the context of a story. We hit performance measures on those 9 quality measures that were at a level that we would have been entitled to recoup some of the savings that we had generated for the system. Well, it turned out we didn't generate any savings for the system. We know because we reduced ER visits significantly, and in some other areas that we did generate savings, but we spent them someplace else, probably on a lot more behavioral health services, which is a key focus of ours, as well as oral health and frequent visits, both with the primary care providers and our nurses, particularly around chronic illness management, and we are just fine with that. But Sometimes life is fair. Because we did well on the challenge measures, we could go back and take some of the savings that were generated by people who saved money but did not achieve high performance measures. I know that's a complicated description, but trust me, kind of all works out in the end. But this is what I want to say about how you get there. You can't move from wherever you are to a more value-based, population health-driven practice without a real disciplined approach. Making changes to practice, as those of you in the field know, in workflow, in clinical protocols, in training and analytics, and back to workflow is a huge lift. And in my experience, this is where we too often fall short. With all of our education and training, I hope I don't offend anyone, I don't think we often enough have been trained across the board, from clinical to operations to executive leadership to academics, in a disciplined approach to making change. So whether you call it change management or use the Dartmouth clinical microsystem approach or lean, this is critical. And I have a set of slides here, not going through in detail. They're for those who are interested in later. But there are slides that give you a sense of what I'm talking about. And my deepest conviction that if we can't change at the level of the practice, we can't sustain that change. Maybe more than figuring out the financial model, this was the area of real learning, starting with our first initiative, which was to implement more robust behavioral health screening in primary care. And out of this came many playbooks. You can see them all listed there. They're like a recording of our lives over that first year, and we've continued to go to these playbooks, add to them, refine them, detail them, and make sure that no institutional memory is lost when people leave the organization. And this is what we came to in terms of critical staffing. You know, a core group started with no additional staffing. We made investments in 2 data sets externally. Patient ping to tell us where our patients were and when they were there, essential to driving down those ER rates and preventing readmissions and following up on hospital care. And Care Analyzer, which came to us actually via our Department of Social Services or Medicaid, that gave us the overall look at the patient's risk score and total spend, so we could do some stratifying of our highest risk patients and make sure when they called, they got a different answer than, even if they were just calling for a routine problem, they went to a group of nurses who really assessed how they were doing overall. Over time though, we had to add staff, we had to add special talents, the team grew bigger, and this is going to be different for every organization. Whether it's community health workers or behavioral health coordinators, population health RN, this does take an investment of additional staff expertise if you're going to do it at scale, but you can start small and do it thoughtfully. And I would wrap up this section by saying, here's a list of questions for those of you who are novices, and I assume we have a lot of experts in the room. If you're a novice, here's a set of questions to ask about your own organization, your own practice, kind of your own knowledge to assess where you are with value-based care and performance health. So let me pivot to, where does telehealth fit in with all of this? Well, I think we can all say we're living through a period of rapid change. We have wanted to embrace telehealth for years. Last fall, we charged a group of our behavioral health staff with modeling up what telehealth would look like in behavioral health, even though we didn't think we had a chance of implementing it on a large scale since there was zero payment for it. It took a pandemic to move the needle at all, and that's this paradox I speak of. Between March 8th and March 22nd, 2 weeks of 24-hour days, of course, 7 days a week, thanks to an amazing dedicated staff and the lack of any other viable option, we moved from zero synchronous telehealth live time between patient and provider to 90% or more of our 2,500 visits or so a day being delivered virtually by either telephonic or telehealth audiovisual, and about 10% of care in person. Every bit of the work that went into creating this population health value-based care model, every one of those playbooks and data sets was incredibly helpful as we stood up a new system using both audiovisual and telephone only, and recreating that choreography of team-based care. Now, instead of the pod, each team person at their home. And we asked all the way through, in our new reality of dramatically accelerated telehealth subsequent to this pandemic, are our efforts increasing value in care? Are they accelerating that increase in value, or are they diminished? Is our ability to focus on the health of our populations and subpopulations enhanced or restricted? I would propose to you that the paradox of the pandemic is that we just may be able to make changes we always wanted to, and in fact we have, but that payment models did not support. We may be able to provide higher value care to everybody by making it more accessible, more convenient, more timely, more cost effective, closer to more at-risk patients for whom our in-person only systems just don't work. I also think it's possible, though too early to tell during this rapid change period, that this may be a contributor to reducing provider burnout that we've heard so much about, as perhaps we shift to a system in which we bring into the office those people who need to be seen in the office and continue to provide care virtually for others. Now, we can't do this alone. Obviously, our staff did an amazing job. They created patient engagement teams, telephone outreach teams, a COVID nurse practitioner staff triage line out of former school-based health center clinicians who couldn't practice in the school. Our tech workers were amazing. But we could not do this without our regulatory partners. Crisis is disruptive and creates opportunity. A lot of you are policy people. You know that Medicare announced what we considered radical new flexibility for federally qualified health centers to provide services by telehealth, audio, telephonic only, and audiovisual. They also got rid of that 40-year annoyance to me of only a physician could sign home care orders, but that's a separate issue. Medicaid in Connecticut really stepped up to the plate. Leaders were very committed that the Medicaid population not lose access to care, and over a period of really not many days, with many, many phone calls with healthcare leaders around the state, new policies were crafted to last either the length of the COVID emergency or to last in perpetuity, as in the case with behavioral health being available by telehealth under Medicaid statute. This was huge, and I can not say how important it is to build those partnerships with our policy players over time. I think we all recognize the incredible contributions that each sector makes. So this was critical to our success. Now, a crisis also requires a focus on core goals and values. And we laid out ours of how we were going to survive this rapid change cycle and this transition. We were going to maintain continuity with our patients. We were going to continue to have access to new patients because other practices were closing. We were going to replicate this high performance team model. We're going to maintain our commitment to staff with no layoffs and no furloughs, which was a big, ambitious statement to make, but we've been able to honor it, in part because we've executed on telehealth. And we're going to build a new system forward. We're going to be very aware that this was a once-in-a-lifetime opportunity to transform healthcare for another generation. And how did we do? Again, not going to draw you to the numbers. They're just examples. One day drawn from March, one from April, May, June. But you can see a practice that was seeing over 2,000, 2,000 to 3,000 people a day, 90% of it transformed to telehealth starting in March with about 10% in person. Now, of course, shifting a little more back as we work to catch up on some of the pediatric well child care, immunizations, well person care that had to be done in person that we might have missed. That model of care, I'll just give you one example in the lower part of the slide, the EHU, if you ask what is that, electronic warm handoffs from medicine to behavioral health, making sure that a patient the primary care provider was talking to was asked, were they struggling? Were they feeling they needed some behavioral health support, and being able to connect them with behavioral health virtually? To date, since the start, over 1,000 patients have had electronic warm handoff, and many of those went on to continue to have care. On the right-hand side, you can see that we continue to honor that commitment to new patients. And how did patients feel about this? Well, I pronounced early on that patients would not like telephonic only care. They would much prefer telehealth care with audio and visual. Always happy to acknowledge when I'm wrong. I was wrong. Patients really like that telephonic care. I think it was just easier, maybe less stressful. We probably have to dig into that a little more, but telephonic care has been the most satisfying, but not far behind is telehealth. In-person care during this period of time, and this is just data since March, maybe suffers because they may not be seeing their usual source of primary care in the office. That's kind of a big gap, but interesting data to have. And if you look at that squiggly turquoise line on the right, during the current quarter, that turquoise line tells you, yep, telephonic care seems to be, when we look at a large sample of patients, and our patient satisfaction company, Crossroads, does an amazing job of reaching about 98% of the sample of patients that we give them. You can see people really like telephonic care. They also really like telehealth care. That in-person care lags behind. And certainly, if you take the rolling past 4 quarters, we're way ahead of it in this quarter. I think that's a paradox too. I don't think that most people would expect that patients were more satisfied with their care in the telehealth environment. And what is that related to? Well, I think it probably is related to a few things. And in the interest of time, I think I dropped out one slide that just showed how much time people saved. People who are stressed, they have a lot going on. They may have to take the Medicaid taxi service or public transportation to get here, but people overall said, yes, I saved time by having this via telehealth. Most important to us, with an N of 408 people, and this was all telehealth. I think this was disproportionately behavioral health patients because medical started more with telephonic and then moved to telehealth. People were satisfied with the telehealth and the scheduling instructions that they got, and they're mostly interested in using it for future appointments as well. And let me just, before I go to my community engagement slide, I just want to read you a couple of the comments, because the voice of the patient is always super important. And here's a few comments. With the new normal Americans have to deal with, I'm very impressed with the way CHC initiated this new process. And here's another one. I hope these visits continue. They are a great therapeutic help to me, and the convenience of video is wonderful. And another, I wish this was standard practice rather than in-person visits. It's more efficient, and strangely, it's more personal. Now, of course, we have times when we get feedback from patients that is critical or indicates their experience was not of that quality. The video quality was bad. I ended up doing voice only. Well, I'll tell you, as an older person, like a grandparent, I just couldn't get used to it. And a third, I couldn't see the provider on video. All of that is by way of saying you don't just stand up a telehealth system and trust that it's all going to work. We could take another hour to talk about the choreography of the offstage players that make telehealth work for our patients. The patient engagement team who's there to both help establish the patient, but also anytime anything goes wrong, to connect with the patient and see what the problem is, help them resolve it and move forward. We couldn't do it without all the people who've moved into our telephone outreach team who are charged with using our population health data to make sure that patients understand that we are still here for care, that they still need the care that they needed in January, not just the care that they need now, and to bring them in for care in a telehealth way. And so that population health value-based care team is working incredibly hard on reaching out to the people that you would probably expect, people living with chronic illnesses, people who've suffered from behavioral health issues in the past, people who are due for well child visits and parents may be afraid to come in. So talking through that and arranging for the well child visit telephonically or by telehealth, and the immunizations to be done in a very fast, I won't say drive-through way because we do bring them into the office, but minimizing the amount of time and contact they have to have in person, because as you all know, people are very frightened by this epidemic. So where do we go from here? Do we think there'll be a large scale run for the exits of telehealth and back into being on getting care in person? I don't think so. I don't think we're ever going back to the old days. My guess is there will be a sorting out, and certainly we'll see a shift as time goes on, and particularly if we don't see a second wave of COVID increases in the patient population. But we're going to be very thoughtful about who comes in, let patients participate in this choice. We also recognize that probably some providers will prefer to only do telehealth. And while I don't have provider level satisfaction data here to share with you, I will tell you that many of our providers love it, find it incredibly satisfying. Some had concerns about being exposed to COVID because of their own health conditions. And at the end of the day, I think we'll have 4 groups of people, people who work exclusively at home, people who provide care exclusively in person, and people who do a little bit of both, some in person and some telephonic. And I think our patients will probably behave the same way. So I'm going to wrap up by just saying that for all the wonders of telehealth, we really miss engaging with all of our patients. And in addition to the personal care, we miss all the community events, all the health fairs, all the engagement activities, the Pride Day parades down Main Street, the homeroom for kids, the family wellness centers, and we look forward to that. We did not build these beautiful primary care buildings like you saw in the beginning to stand mostly empty. We look forward to having them filled with our patients again, filled with the kinds of activities that we think really advance health and wellness in community, and to helping move forward our objectives of achieving longer, healthier, more satisfying lives for all of our patients. Thank you so much for your attention this morning, and I look forward to an opportunity to answer any questions, or more to have a discussion. Thank you.
Wonderful. Thank you, Dr. Flinter. We are looking for some questions. If you would like to add your questions to the Q&A box, please do so. Dr. Flinter, maybe you could speak a little bit to how you've learned how to put together a program, and how you are seeing the future kind of unrolling now that COVID has hit and we're all moving through the new normal.
Sure. A program of telehealth, a program of value-based care, population health. You want to narrow that down a little bit?
Let's start with value-based care.
You know, I can tell you that we all think that we have provided high-value care, right? And I tried to get that with my little bit of problem that I have with the definition. All of our practices have focused on quality and on performance, making sure that we're using the latest evidence-based knowledge. But too often, we did not have a very disciplined approach for how we measured our progress towards goals. We did not have a system for implementing change to see if we could improve them. We all know we should do quality improvement, and we do quality improvement projects and often retrospective, but how to really change things, which is why I focus so much on those playbooks and adopting a formal change process as being critical. And the third piece is you can't do it if you're flying blind, right? Without the data. And until the PCMH Plus program really came about, we just, we knew people had been in the emergency room, several days later when we got the note from the hospital electronically, but we didn't have it that very next day. The same with knowing who else patients were seeing. I remember looking at the data when we very first got it about our attributed patients, and we sorted and stratified it, and I looked at the highest risk, highest spend patients at the top, and all of my training and education and literature that I'd read to date said that these were likely to be our patients with severe chronic alcoholism, with severe behavioral health disorders, disconnected from care, et cetera. Well, I was dead wrong. They all had very complex medical problems, I think most oncology, and we weren't seeing them at all. And we had lost them in primary care because they were so absorbed in a other complex specialty system. And it really gave us an opportunity to reach out and make sure that we still stay connected with those people, to offer perhaps the behavioral health support that they needed or the nutrition support, and to maintain their ongoing primary care. So I think taking advantage of those things, knowing where you are, a disciplined approach to change, making sure that you have the data, and then, last but not least, you have to have buy-in from leadership to do this, for people to come together around the table to look at these goals, to create this kind of change is not fast and it's not easy. And we literally met every single week, this core kind of population health team, along with a good number of clinical and organizational people within the organization, very focused agendas to continue to move forward as we increased our mastery of knowledge around value-based care.
We have a couple more questions from the participants.
Sure.
One participant asks, for this to work and health outcomes to be met, it seems to me that we need to be fully embedded in communities. Can you give some tips on working with communities and how to find out about the community health needs and how to put the team together to meet community needs? Any
Sure.
tips for rural and underserved would be helpful. Thank you.
Perfect. Perfect. Well, that is a great question, speaking as a community health person. And, you know, I think my first not highly technical, sophisticated advice would pick up the phone and call people. Show up. Go extend yourself. Find out what the community-based organizations are, whether they're faith communities or they're organizations that are more social in nature. Go out and meet people. It is one of the great rewards of being in healthcare is to know your community and to know the people in it and know their concerns. So there's no substitute for showing up. Go to Common Council meetings, go to the Public Health Committee meeting, as I say, go to the local action committees, go to the food pantry. If there's a homeless shelter, find out who's leading that effort. The second is if you have a community health center, go learn about your community health center. I haven't visited your health center in Fort Myers, but my guess is that they could tell you both at a large level and a very granular level, what are the health needs in their community and what are they doing about it? Most community health centers are deeply connected. Remember, they all have a patient-dominant board of directors. They all do needs assessments every year. They look at their data, they report on their data, but more than that, they're deeply engaged in a personal level in their community, which is why, you know, the state of Connecticut has come to us to ask us to stand, and all the health centers in Connecticut, to stand up, pop up clinics in high-risk areas for testing for COVID, because they know where they know that we know where the people are, and the people know that we're a trusted community health organization. The third, just on a purely educate yourself and inform yourself. Under the Affordable Care Act, every nonprofit hospital had to do a comprehensive needs assessment for their community, their catchment area, every 3 years. That's still in the legislation. Don't think that's been struck out yet. They have turned out to be a gold mine. The hospitals, I must say, in Connecticut, and I hope this is true in Florida and other places, really took that charge seriously. Brought people to the table, brought people to the table to inform the hospital on what they ought to be looking at, and then use data to help support it and craft priorities for intervention. So you can look up your local hospital's community. If you have a nonprofit hospital in your community, I make an assumption that you do, you can look at their needs assessment for your area.
Okay, thank you. Another question from our participant is fabulous presentation. Thank you for weaving together population health, value-based care, caring for most at-risk populations, community-based care, all under the umbrella of opportunities unique to telehealth. As a family nurse practitioner and a CNM, do you have recommendations specific to successfully establishing outpatient prenatal postpartum care at community health centers with hospital-based intrapartum care?
Thank you for, that must be somebody I know who knows how much I love prenatal care and how much I believe it needs to be part of the community health system, or there needs to be a very close partnership with other people who are delivering that care. So yes, community health centers are responsible for, they have to show that they either deliver it directly or deliver it by agreement with somebody else. And if somebody else is doing it, that they adhere to the standards of no denial for lack of ability to pay and so forth. So we fully integrate prenatal care into our program at most of our sites, but not all of our sites, because certain regions really do have that covered under somebody else's work, often a hospital-based clinic, though I'd like to have one every place. But it's fully integrated into this team-based model of care, has that same approach to population health. We are looking early and often at when people come into prenatal care. You might have noted that was one of the core measures, and whether we are able to get them back for postpartum care. And then you think about your prenatal patients and what we talked about in terms of the importance of both the on-stage and the off-stage players, right? you really need that behavioral health person. Some of you may use a centering healthcare model. We don't use the formal model, though I admire that one very much, but a high degree of personal support for people, offering groups, making sure in particular, if there are issues with substance use disorder, and of course, we see quite a bit of opioid use disorder, making sure that that is addressed early and often, that diabetes is mitigated. So yes, it's a long way of saying prenatal and postpartum care and intrapartum care can all be integrated into a community health center, but it doesn't all have to be done by a community health center if you have a very good, strong partner that can adhere to those standards and make sure that your most at-risk patients, whether that's social need or medical need or behavioral need, gets the care that they need. We watch birth outcomes like a hawk, review every adverse outcome, low birth weights, and really do our very best to make sure women have an opportunity to plan their families and to have the best birth outcome they can have.
Another participant said many families in rural areas lack adequate internet access. How might we make telehealth more accessible to those rural communities?
Thank you. I probably didn't focus enough on the digital divide, which I think you're probably all familiar with. And this is a national problem, needs to be addressed. There have been, under the many buckets of funds that have been released during this COVID pandemic, there is one bucket through the FCC, I believe, that really is targeted to go to areas that do not have robust broadband and to get it there. I'm not an expert in that area. I don't know that it's enough to fully meet those needs, but I know there is a recognition that the digital divide is an impediment to people who live in rural areas in terms of accessing full telehealth audiovisual. But I'll tell you, it's part of why we have been such fierce advocates for Medicare and Medicaid continuing to honor, and I know our state Medicaid's approval of telephonic only care as eligible for payment is right now limited to the duration of the epidemic, though I'm very hopeful based on the results that we're seeing that it will be continued. But to at least to pay for telephonic services in and of itself, that crosses the digital divide. And I know some of you are probably thinking, well, not everybody has a phone, and it's true. You don't always have a phone, but most people have at least access to a phone and can do the visit that way, at least until they can have the visit in person. I have been surprised, I really have been surprised, as I said twice, I think, in the presentation, by how much people value the telephonic care and feel they're really getting the benefit of the visit. Of course, it leaves something short in terms of what you can see. We've crafted a whole complicated system. It actually works very well. It may have been complicated to craft. It works very well, of how to upload pictures. It'd be easy if we did it like we do in our regular life. We take a picture on our cell phone, we send it to somebody. That doesn't work in a HIPAA environment, right? And so many procedures have to be in place to protect that privacy. But the long and the short is we need broadband everywhere in our rural areas. We need access for people to healthcare through both telephonic and telehealth means. And I hope that continues after the pandemic.
Another question is, wonderful presentation. I am thinking about starting a nonprofit health prevention clinic to help disparities in my area. I would like to know where to go and how to start it.
Well, there you go. I probably could do that in a minute. First, I think what I want to say is go for it. Congratulations. You have a lot of work ahead of you, but it all begins with a single step. In my selection of photos for today, I always look at some historical photos, and one of my favorites was the very first office of the health center. Before that storefront clinic that I showed you was actually a second floor walk-up apartment with a couple of dental chairs. So you start wherever you are. You start with your passion and discipline and a commitment to be in it for the long haul. These organizations aren't successful because people come and go, though some of course will. They're successful because somebody perhaps like you who are raising the question have a vision, an idea, your eye on that horizon, your feet on the ground, and you're going to make plans and you're going to try and bring people along with your enthusiasm in terms of where you can go for help, I think there's a lot of resources. Certainly, the National Association of Community Health Centers, if you're thinking about a clinic that would qualify as a community health center, has a lot of resources. And if you want to reach out to me, my email is there. I'd be happy to put you in connection with some other people based on where you are and what it is that you're thinking about doing.
We have time for maybe one or two more questions, and I see a couple of just kind of brief questions here. One is, are OTs and PTs part of your community health teams?
Mm-hmm. That's a great question. And I noticed that you had physical therapists and occupational therapists among the health disciplines that you train for. We have very good access to PT and OT. And so we have done that care by referral, not by having them be part of the health center staff directly. But a community health center can request, you have to file something called a change in scope to add those disciplines. And over the years, we've added many different disciplines as we saw the need or experienced difficulties in getting to them. For instance, in some states, chiropractors are not paid for under Medicaid in the community and private practice, but they are paid for if the chiropractor is providing it as part of a community health center. So some of these are nuanced, but they're very important services. And certainly with our focus on children and youth with special health care needs, we've really come to value and treasure our OTs even more. And physical therapy has always been part of our core team of people we refer to for care.
Thank you. This is a follow-up to the OB question, and there has been a rise in birth center interest currently given COVID. Do you know of examples of birth centers working collaboratively with or alongside of community health centers?
Mm-hmm. I do. And again, just so I got the names right and so forth, if you want to shoot me an email, I'd be happy to respond to that. Yes, I've read about the uptick in interest in both home birth and also the use of birth centers because of people's just concerns about being in a hospital setting. And of course, I think it's wonderful for women to have a range and options of where they choose to deliver.
Okay, thank you so much, Dr. Flinter. We just maybe have a minute or two, and I was just wondering if you had any final thoughts that maybe you would share.
Yeah, I do. One, I want to thank you for the opportunity to be here because, of course, it gave me an opportunity to reflect upon what it has taken to navigate this period of time in terms of our own healthcare system, our commitment to our patients and our staff, but certainly having kind of gotten our legs back under us thanks to the unbelievable work of our team, having done this conversion to telehealth built on previous strengths. It's really, I think, these last days of the turmoil in our country that has captured, I think, our hearts and minds and our intentions of why do we do this work and why is it so important that we do it exceptionally well, that we be so aware of what is not right in our country, in our communities, not just in healthcare, but what can we do in healthcare, that lever that I talked about, to be organizers in a way that helps to advance the quality of life for everybody in communities. I'm not sure we have talked about all of that as much as we should. I will send out to you so it can be posted for the participants. But yesterday, that Project Echo I talked about early on, which has just turned out to be a great communication vehicle for us with people, offered a presentation that included a number of our staff, our medical director for psychiatry, one of our behavioral health clinicians who works very much with adverse childhood events, one of our organizational executives, a regional vice president, is very engaged in our communities of color around the state, one of our nurse practitioners who's the chief nurse officer and a gentleman who heads up the National School-Based Health Alliance. And they offered, we sent out an offering, we were going to do an hour-long conversation on racism and what can we do to heal the country, and where does healthcare fit in with this. 5,000 people signed up for it. 5,000 people from around the country, with all that people are doing, how busy they are. It was a very powerful conversation, and I really would love to send the link out to you afterwards, and perhaps you can distribute it to your attendees. But it really drove home how important the work everybody who's here today is, and why, and asking ourselves why. So that's really my final message. Everything else that we've talked about are really organizing strategies, right? They're organizing principles to get to that good end: longer lives, healthier lives, more productive lives, and building healthier communities. And I'm very proud. I have never been more proud to be part of our great national healthcare community than I have over these last couple of months. And all those, pot banging and singing and cheering that's gone on for our frontline workers has been so wonderful. But COVID's going to end at some point. We need to be doing the work to make sure that we are making life better for everybody, and doing what we can in healthcare to make that true.
Okay, thank you so much, Dr. Flinter. We truly appreciate your knowledge and experience, and we're going to, actually we have 1 minute and somebody snuck a question in here. Do we have time?
All right, let's give somebody the last question.
Okay, this is going to be the absolute last question. And that is, have you thought about collaborating, or are you already using academia students in your center?
Oh my, yes. So when I said training the next generation, back in the beginning of the presentation, formal programs, postgraduate residency, all those sorts of things. But at any moment in time, pre-COVID, there were up to 300 students throughout the system, all the disciplines: chiropractic students, nursing students, MA students, social work students, psychologists, medical, nursing, the entire gamut. And when I talked about the pod, I talked about how important it is that we always think about a seat for a learner or a trainee. We are passionately committed to training the next generation. And those playbooks that I showed you early on, if you have an organization that's not taking students, a healthcare practice that's not taking students because it's complicated and maybe it's disruptive and they're not quite sure how to do it, we have a playbook for that too. And in fact, offer webinars through our National Cooperative Agreement on Clinical Workforce Development on how you can bring in students. I think every healthcare practice needs to embrace student education and training at least some level. And it can be as simple as one medical assistant externship. It can be as broad as ours, but this is critical. And again, we need to be training our students, not just to clinical quality and complexity, but we need to be modeling for them this high performance model of hopefully very satisfying care. And to all the students who are here, if there are any, I also want to say, I know your lives have just been disrupted by this COVID pandemic, and carry on. Things are going to get back to a normal, maybe a different normal, but a normal in which you can complete all of your clinical requirements for your degrees.